All right. Hello, everyone. Hope you're all having a great day. My case study focuses on a patient with acute pancreatitis. Here's just a quick little layout of the presentation. First, I'll give you all a brief overview of the disease. Then we'll get into the patient, start with an introduction and history of the patient, and then move into our assessment, follow-up, and interactions with the patient. Okay, the definition of pancreatitis is the inflammation of the pancreas. It can either be acute or chronic, and as I mentioned earlier, we will be focusing on a patient with acute pancreatitis. Pancreatitis is characterized by edema, autodigestion, fat necrosis, and hemorrhage of pancreatic tissue. Symptoms of acute pancreatitis that are common are upper abdominal pain radiating to the back, nausea and vomiting, abdominal distension, steatorrhea, and in severe cases, they are sometimes complicated by hypotension and dehydration. And as you can see in the picture to the right, the pancreas lies just below the liver and behind the stomach. All right, to talk a little bit about the disease course, the exact mechanisms that lead to pancreatic injury are not fully understood, but there is a common characteristic. There seems to be premature activation of the enzyme trypsin within the pancreas that results in autodigestion of the pancreatic cells. The enzymes released by destroyed pancreatic cells then eventually reach the bloodstream, causing elevated serum amylase and lipase levels. The immune system and other mediators of inflammation cause an increased vascular permeability, resulting in hemorrhage, edema, and eventually pancreatic necrosis. These mediators can also cause systematic complications such as bacteremia due to GI floral translocation, acute respiratory distress syndrome, pleural effusions, GI hemorrhage, renal failure, and ultimately systematic inflammatory response syndrome, also known as SIRS. So the diagnosis of pancreatitis can be based on the following: clinical symptoms, an ERCP, abnormal serum amylase or lipase levels, BUN levels, and CRP levels. As you can see here, treatment in a mild case is much different than the treatment patients with severe cases receive. Mild acute pancreatitis focuses on administering IV fluids for hydration and analgesics for pain relief. Severe acute pancreatitis focuses on providing aggressive supportive care, decreasing the inflammation, limiting infection, identifying and treating complications as appropriate, providing fluid, electrolytes, nutrition support, and in some cases antibiotics and surgery if needed. And research actually shows that fluid resuscitation is the intervention that's most likely to improve clinical outcomes. All right, now to move on to nutrition therapy for acute pancreatitis. Nutrition implications. Research supports feeding patients without delay as tolerated. For severe cases, early initiation within 48 hours of enteral nutrition is recommended in order to maintain nutritional status, minimize losses, and to prevent intestinal bacteria translocation. Nutrition intervention. Start enteral nutrition support once patient is stabilized or within 48 hours of admission, as mentioned above. Goals are to provide adequate kcal and protein, minimize nitrogen losses, and manage imbalances, which may include hypo or hyperglycemia, hypertriglyceridemia, and imbalances of micronutrients such as calcium, magnesium, and vitamins. And then under the monitoring and evaluation, weight measurements obtained weekly, adjust the nutrition regimen as necessary, but overall, improvement in symptoms with progression towards resuming oral feedings is the primary outcome goal in nutrition treatment for acute pancreatitis. All right, now to get into our patient. Our patient is Mrs. W. She's a 30-year-old white female. And here you can kind of scan through these past medical history components. But one that I would really like to point out is that this patient was hospitalized for acute pancreatitis back in May of 2017, where she had to be intubated, and her acute kidney injury was so bad that they actually had to start her on dialysis while she was in the hospital. So as I was going through her history, when we were first assessing her, this is what stuck out to me the most because it kind of shows the severity that this course of her acute pancreatitis could take, and something that we need to be aware of. All right, social history. The patient smokes about a half pack a day. She reports not drinking any alcohol. She has a 2-year-old daughter who lives with her mother, and she lives with her boyfriend. And actually, just to go back real quick to the past medical history, um, I think it's important to point out a few more things. For example, the patient has bipolar illness as well as PTSD, and those I think are also something to take into consideration. And then just looking through everything else gives you a really good picture of her background. All right, now we'll walk through some of the admit information. So this patient, Mrs. W., presented to the emergency department on September 30th, 2017, complaining of pain in her left upper quadrant since the day before. She reported nausea and vomiting that was bilious in nature. She denied a fever, chills, or a productive cough. Excuse me. Patient underwent abdominal and pelvis CT in the emergency department, as well as a chest CT, with findings suggestive of acute pancreatitis and possibly pneumonia. Patient presents tachypneic and tachycardic. Currently, it was unclear if there was any underlying infection. And then I sort of already went through these before, but these are from the radiology note, so I thought it might be important to include. The CT of abdominal and pelvis with contrast showed a normal appendix, showed pancreatitis, and also showed a right ovarian cyst. And then the CT of the chest showed no pulmonary embolism, bilateral lower lobe pneumonia, fluid in the upper left abdomen, which indicated acute pancreatitis, but as it mentions there, clinical correlation was needed. You can't just diagnose pancreatitis from that. Okay, and then these are her 4 main admit diagnoses. So of course, acute pancreatitis, which is what we're going to focus on, pneumonia, atypical chest pain, and hypertriglyceridemia, and her triglycerides were actually over 5,000 on admission. And I thought it would be important to list here that the normal levels are less than 150, so that's a really high level. And actually, the dietitians that I've been working with, they were just like amazed by that. So that's the highest level that they've ever seen. All right, now to get into the good stuff. So nutrition care process, and we will start out with the assessment of the patient. So this is the first time we've seen the patient. We assess her needs and everything else, and that's what I'll walk you through right now. So we received a consult to initiate enteral nutrition. And then I'm just going to give a little overview. It might be a little bit repetitive of what we've already talked about, but it's what I included in my note. The patient is with acute respiratory failure with hypoxia, likely complicated by ARDS associated with pancreatitis and pneumonia. Triglycerides over 5,000 on admission. The patient also has an acute kidney injury, complicated by uncontrolled type 2 diabetes and a history of requiring dialysis due to acute renal failure in May of 2017. And that's what I pointed out quickly in her past medical history that I thought would be important to note. The patient required intubation last night, September 30th, on day 1 of hospital, due to ongoing respiratory acidosis, hypoxia, due to ongoing respiratory acidosis and hypoxia despite continuous bypass. So she was intubated the night she presented to the hospital, and we are seeing her the following morning. All right, let's talk a little bit about the gastrointestinal detail. Per patient, her last bowel movement was on the 27th of September. She had an NG2 placed this morning, and the KUB, which is essentially an X-ray of the abdomen, showed that the feeding tube is in the third portion of the duodenum. And on admit, patient presented with nausea and vomiting and left upper quadrant pain. Patient has a distended abdomen. Her skin is intact, so there's no wounds or ulcers. She has 2+ anasarca. Her Tmax, which is essentially her highest temperature within the last 24 hours, and this is important because we use this to calculate needs. Well, actually, we won't use it to calculate needs in this patient because she's obese, so we do it a little bit differently. But if this patient was not obese, we would use Tmax and the vent settings to calculate her needs using the Penn State 2003b equation. These are her vent settings and her I's and O's, so intake and output of fluid. And then over here, you'll see a little picture that I just thought was a little interesting if you don't have much of if you're not in clinical and you don't have an idea of what a vent does. But it essentially just hooks up to the patient, the tube goes through their mouth and into the windpipe. The mechanical ventilator blows air or air with increased oxygen through tubes into the patient's airways. Air flowing to the patient passes through a humidifier, which warms and moistens the air, and exhaled air flows away from the patient. You'll see right through there, and then back through the machine. And vented patients are in the ICU so that they can have a nurse periodically check on them, and it's a lower nurse to patient ratio in the ICU. All right, now we'll talk about anthropometrics and needs. So you can see here her height, she's 5'1", 200 pounds. Her BMI is just under 38, which classifies her as class 3 obesity. Her ideal body weight is 105 pounds. And then her estimated energy needs are all listed here. And this is what my hospital, CHS Pineville, follows. The patient is obese. We calculate their needs 11 to 14 kcals per kilogram if they're obese and in the ICU and vented. Sorry about that. Calculate the protein based on their ideal body weight, giving them 1.5 grams per kilogram. And then because she is diabetic, we calculate her carbohydrate needs as well, and we do that based on 45% of her calories need to be coming from carbs. And that's an estimation, but it is something that we do if a patient's diabetic. And fluid, we always recommend 1 milliliter per calorie to meet baseline needs or per the MD. And of course, this changes if diseases are different, but in this specific patient, this is what we would do. All right, so her sodium, potassium, phosphorus, and magnesium are all within normal limits. Her bun and creatinine are both high. Her lipase levels were elevated at admit. They were 212, but have since returned to normal levels today. So on day 2, her lipase is back to normal. And they actually didn't do an amylase reading, so we don't have that. Her most recent triglyceride reading is 1,822, so still very, very high, but thankfully has climbed down from the 5,000 reading that we got at admit. She has an A1C of 10, so that's showing us that she has uncontrolled diabetes. And her calcium is low. And having a low calcium is actually quite common in acute pancreatitis. And one proposed mechanism for hypocalcemia in acute pancreatitis is seen in the early phase of the disease, and it's autodigestion of the mesenteric fat by pancreatic enzymes, and that begins to release fatty acids, which in turn forms calcium salts. So that's sort of one of the proposed ideas of why that calcium is low in patients with acute pancreatitis. But like I said, it's unsure. That's not proven by a lot of research. All right, and then when we go through our assessments with our patients, we always write down the medications that are pertinent to nutrition, and also just important to know that a patient is on. So here we have fentanyl, which is used for sedation and respiratory distress. We have Endotool, and that manages glucose control. Presidex, which is a sedative. And then this patient is on 2 antibiotics. And it's important to note that when a patient's on these antibiotics, it's even more so important to monitor their renal function. And then with the level down here, it's also important to manage blood glucose levels in diabetics because it's known to either create hypoglycemia or hyperglycemia. The patient is on a bowel regimen, so the patient's taking Colace and Miralax. Patient is receiving Pepcid, pravastatin, which is an anti-hyperlipidemic, and fenofibrate, which is also an anti-hyperlipidemic, and that one's specifically to treat increased triglycerides. All right, so we came up with 2 different diagnosis statements for this patient. The first is altered nutrition-related lab values related to acute renal injury and pancreatitis, as evidenced by elevated BUN and creatinine levels, severely elevated triglyceride levels, and low calcium related to acute pancreatitis. Our second is inadequate oral intake related to intubation and respiratory failure, as evidenced by severe acute pancreatitis and ARDS. All right, then we are going to initiate enteral nutrition within 48 hours of the ICU admission, and this was our first goal. And since we were receiving this consult the second day, within I think even less than 24 hours of her admit, we're going to meet this goal. So we check off that goal is met. We're going to initiate enteral nutrition to meet calorie needs, meet protein needs, and hope that the patient tolerates this nutrition support. And so that's our second goal. And our plan is to recommend beginning a low-fat trophic feed with vital high protein at 20 milliliters per hour to provide the patient with 480 calories, 42 grams of protein, and 54 grams of carbohydrate, and 11 grams of fat. And so we're just going to slowly get her started on this trophic feed. We don't want to start right at goal rate. We want to make sure that the patient's tolerating it. And this is sort of how we go about doing that. All right, and then we are going to monitor by following her renal status, pancreatitis signs and symptoms, triglycerides levels, and closely monitor to make sure that we chose the appropriate formula of low fat versus Nepro. So if we find that her renal labs are getting all wacky, her acute kidney injury is getting worse, we may have to switch her to Nepro instead of the vital high protein that we have her on. And we plan to follow this patient 3 times weekly, plus daily and ICU rounds. And this is really typical of any ICU patient for us at CHS Pineville. All right, and now we're going to move into our follow-up. So these are going to be further interactions with our patients following the first day's assessment. So we saw the patient the following day on October 2nd. This is patient's day 3 in the hospital. And over here you'll see we noted any changes in her assessment. So skin is intact still. Anosarca's gotten a little bit worse. Tmax of 101.3. You'll see her vent settings listed. This last bowel movement, that should be 9/27. So she hasn't had a bowel movement since admit. NG tube with the end in the third portion of the duodenum. See her I's and O's. And triglycerides have gone down even further, which is great, from 5,000 to 1,800 to 577 today. Calcium's still low. Her BUN, and creatinine have gone up slightly. They're still high, and she has a GFR of 19. No changes in her medications from the original assessment. And then here I listed our assessment summary. Hospital day 3 with minimal nutrition, NPO for pancreatitis, and then intubated on the 30th with post-LOT feeds starting on the 1st of October, which is yesterday. GERD early trophic enteral nutrition starting by ICU on day 2. Estimated intake meeting less than 50% of needs for 3 days. All right, continued on to talk about this follow-up. We discussed this patient in ICU rounds. She is NPO for pancreatitis, and we are going to plan to bump up her tube feeding regimen. So right now it's at vital high protein 20 mils an hour. We're going to bump that up to 30 mils an hour today, as well as adding ProSource twice a day to help the patient meet needs. This regimen will provide a total of 800 calories, 92 grams of protein, and 81 grams of carbohydrate. Our final goal rate, which we are hopefully going to bump her up to tomorrow if she's tolerating this bump to 30 today, provides 1,200 calories, 105 grams of protein, 135 grams of carbs, 1,000 milliliters of free water, and 84% of her RDIs. The RD will continue to assist and provide optimal enteral nutrition support for the patient's disease state. We plan to get history when able, so once the patient's extubated, and we will provide diet education prior to discharge. We'll continue to follow 3 times weekly and daily in ICU rounds. We'll follow her renal status to see how her acute kidney injury is going with all the labs. Continue to follow her pancreatitis signs and symptoms and her triglyceride levels closely. So that sort of wraps up our first follow-up. So essentially, we just bumped up her tube feeding regimen because she was tolerating well, and just going to continue to watch and see how she progresses throughout the next day. All right, up to follow-up number 2, and this was on October 4th, and this is patient's day 5. Skin is still intact. Her anasarca has actually resolved. Still got a little bit of a temperature. You'll see her vent settings are improving. It's known that when PEEP gets down to 4 or 5, then that means patient can handle being extubated. And so she's at 5 right now, which is a good sign. She had 3 bowel movements yesterday, so that must have been after we already did our first follow-up, so that's good. NG tube still placed. Eyes and nose, you can see that she's diuresing really well. Blood glucose remaining under 180, which is like what we like to see in patients, diabetic patients. Triglycerides still sitting at about the 500 mark. BUN, creatinine are still high, and her GFR is at 18. Not a big change in her medications. She's receiving a high sliding scale insulin. Patient's still on Precedex for sedation, still on the bowel regimen, and receiving the antibiotics. And her weight has gone up about 4 kilograms from admit, and we believe that this is related to fluids, so it's not something that we're going to reassess her needs for or worry about too much. The patient needs a lot of fluids to improve her clinical symptoms, and as you can see, she's getting rid of them well with good urine output. You can see that up in her eyes and nose. All right, and then a quick assessment summary. Patient's improving respiratory status and will likely plan for extubation today. The nephrology is following her for her kidney status. She's got good potassium and phos. Her BUN and creatinine are high, but patient has good urine output, as I mentioned before, and there are no plans for dialysis at this time, which is also great. Discuss the patient in ICU rounds. Patient is still NPO for pancreatitis. We are going to increase the patient to her goal rate of 50 mils per hour, and that'll provide 1,200 calories, 105 grams of protein, and 135 grams of carbohydrate, 1,000 milliliters of free water, and 84% of her RDIs. We'll discontinue the ProSource now that the patient's meeting 100% of her estimated calorie and protein needs. The RD will assist to provide optimal enteral nutrition support for disease state, plan to get history when able, and will provide diet education prior to discharge. RD will follow 3 times weekly and daily in ICU rounds. As before, we'll continue to follow renal status, pancreatitis signs and symptoms, and triglyceride levels closely. All right, we will now go on to follow-up number 3, which is on October 5th, and this is patient's day 6. Skin remains intact. Patient was extubated yesterday successfully and transferred out of the ICU. She's stable, she remains diuresing well, and is in the polyuric phase of ATN, and that is per the MD's note this morning. She also had a bowel movement today, which is great, and she denies any nausea, vomiting, or abdominal pain. NG tube is still placed. You can see that she's still diuresing really well. Labs remain about the same. Triglycerides have jumped a little bit, so we're going to keep a really close eye on those. Blood glucose remains under 180, which is what we want to see in diabetic patients. BUN and creatinine are still high, and GFR of 18. Patient remains on high sliding scale insulin and a bowel regimen. Patient's diet has advanced to clear liquid, so we're going to kind of just see how that goes for the patient. And we reassessed her needs now that the patient's been extubated. And we used the Mifflin-St. Jeor equation times 1. And the reason we did 1 for an activity factor is because she is obese. Protein's been decreased a little bit, but we keep it a little bit higher than normal just because of her pancreatitis and acute kidney injury. And carbohydrates were assessed because she's diabetic. And fluid, 1 milliliter per kcal to meet baseline needs or per MD. All right, in our assessment summary, patient was awake and alert at time of the visit. 2 family members were at bedside. I obtained a brief food history recall, and she expressed her desire to get rid of the NG tube and advance to a normal diet. I discussed with her why it's important for the tube to be left in, just to make sure that she can handle this clear liquid diet and she doesn't have any adverse reactions to it. She was a little bit frustrated, but she did understand that once I talked to her about it. All right, now we'll talk a little bit about her nutrition intake history that I was able to get. She had a hard time recalling what like a typical day of eating would be like. So I kind of went into the questions of more, okay, well, what are some usual foods that you eat, on a weekly basis? And she listed a few things. She said pot roast with potatoes and carrots, fried chicken, Chinese food takeout, and pizza. And after that report, I kind of thought, maybe she goes out to eat a lot. This would be some important information for us to know. Because as we all know, when you eat out a lot, the amount of fat you take in generally increases, as well as sodium and calories. And the patient did report eating out about 4 times a week, although her boyfriend was in the room and he kind of scoffed when she said 4 times a week and said, it's actually a lot higher than that, but the patient didn't seem to agree. And then she also did state that before her admit, she had a good appetite, but she did state that she knows that she wasn't eating healthy. And when I kind of further asked about that, she said, well, I wasn't eating how I should be for my diabetes, and I wasn't eating how I should be for pancreatitis, because she did have diet education in her last hospitalization in May for pancreatitis. So that sort of just reaffirmed with me that, okay, we do need to get some diet education in and give her some good handouts to take home. And then also, while I was leaving the patient's room, I stopped and talked with the RN, and the RN reported that the NG tube seemed to be sliding out somewhat yesterday, and that the patient said that she pushed it back down. And the RN was worried that the tube may be slightly higher than its original placement, and the RN questioned if this would raise patients' triglyceride levels. And so we actually, meaning me and the dietitians that I work with, we actually researched this and got back to the nurse because we weren't exactly sure, because just off the top of our head, we thought, oh, of course, that makes sense. If the tubes come up into our stomach, our pancreas is going to be stimulated more, and that might slow down its ability to heal. But we did find, and you'll read this in the 2 articles that are attached to my questions for the slideshow, that research showed that post-pyloric placement is not required for acute pancreatitis. There's not enough research to support this. So the fact that it may have come up a little bit into her stomach or further or higher into her duodenum should not have caused any issues with the patient's signs and symptoms of pancreatitis. So the RN agreed to continue the feedings as tolerated. Patient has been moved to clear liquids, as I said, and we'll just see how the patient tolerates this. If there are no issues, we will remove the NG tube tomorrow, and the diet will be advanced further. And the patient is continuing to receive vital high protein at the goal rate of 50 mils per hour. We will continue this tube feeding, see how patient tolerates diet advancement, and as I said, plan is to advance diet tomorrow. We will continue to monitor toleration of diet advancement and tube feeding regimen, and will follow as clinically appropriate. All right, now moving into follow-up number 4. This is patient's day 6 on October 6th. Skin remains intact. Patient had a bowel movement yesterday. Patient denies any nausea, vomiting, or abdominal pain. Patient's still diuresing well, good urine output. Blood glucose remained under 180. Triglycerides still around the 500 mark, but not getting any higher, which is what we like to see. BU and creatinine are high. And GFR is improving a little bit. It's at 21 instead of 18, I believe it was at yesterday. And our assessment summary is, so this is sort of what we talked with the patient about when we saw her, and what we found in the doctor's notes prior to our visit. So our follow-up was to check diet advancement and intake, and to provide pancreatitis and diabetes diet education. Patient's diet has been advanced to full liquids. Patient was in chair at time of visit and stated that she was leaving today, which sort of came as a surprise to me because I thought that would be rather soon, even though her symptoms are improving and she's feeling much better. But that's what she said, and she said it was because she really wanted to get home to see her daughter. Patient reported that she had actually sneezed out her NG tube this morning. And, luckily that wasn't a problem because tube feedings were actually stopped last night, around 4 p.m. Per patient's request. So it wasn't a big deal, and luckily she was tolerating her full liquid diet well. She had 100% intake of clear liquids, and everything went well. Patient expressed her desire to go home multiple times during visit. And that made the education a little bit hard to give because she was so wrapped up in getting home to see her daughter, which is, of course, you understand that and you respect that. But she had mentioned that she had diabetes education a few times before, and she did have a good understanding of what carbs were, types of carbs, as well as serving sizes of carbs. We kind of walked through different meals, and she would plan them out based on a 45-gram allowance at each meal. And as far as pancreatitis diet education goes, she understood that pretty well, but she had some misconceptions about that. And she kept stating to me that she was just going to go vegan when she got home, which we sort of had a discussion about how actually it shows that slower changes are better and more sustainable. So instead of just cold turkey changing your diet completely, it may be easier for her and her family if she makes some slow changes that we talked about. And then after I spoke with the patient, I stopped and talked with the RN a little bit to see if she really was discharging. And the RN kind of said the same thing as me. Well, she seems to think that she is. The doctor's going to see her later on. But the RN sort of assumed that she would be another day or two in the hospital. Patient has advanced to full liquids, and the plan is to advance further if the patient tolerates this well. We recommended sending Glucerna twice a day. And a Glucerna is an ONS, which is an oral nutrition supplement. And this would provide the patient with an additional 440 calories and 20 grams of protein. If patient continued to eat or I guess drink 100% of her full liquid diet, she would need to drink about 100% all of her glucernas to meet about 95% of her estimated energy needs. So the reason that we decided to send those 2 glucernas to her was just to sort of supplement her full liquid diet and just keep her getting the energy and the protein that she needs so her body will continue to heal. And we will continue to monitor the diet advancement and intake, and will follow as clinically appropriate. All right, and then patient discharged after insisting she would leave AMA if she wasn't able to go home. So although the doctor thought it may be best to keep her another day just to make sure that her symptoms continue to improve, he did think that she was improved enough to go home. So that was a little bit surprising to us, but we are glad that we did the diet education with her on that last follow-up, and provided her with a multitude of handouts for her to take home for good reference. Here I just listed some abbreviations that I used throughout the PowerPoint, just because I know if maybe you aren't clinical right now, some of these might not be as familiar to you, and I don't know if our facility uses the same abbreviations as others, so I thought this might be helpful. And then here are the references that I used, and that is all. So thank you very much for listening. Hopefully it all made sense to you, and you'll have a good understanding of acute pancreatitis after this. And yeah, all right.